Welcome back to the deep dive. Last time we were really up in the control towers, weren't we? At the hypothalamus and pituitary.
Yeah, the brain's command central for hormones. Absolutely fascinating stuff.
So today we're moving just a little way down, following those signals into the neck. We're zoning in on the thyroid and the parathyroid glands.
Right, these small glands, but wow, they pack a punch. They're running your metabolism, how you burn energy and managing your calcium levels.
Which is just critical for nerves, muscles, bones, everything, really.
Exactly. And our guide for this is, again, Mr. Hostler's Nursing Level Anatomy and Physiology lecture notes.
Ah, yes, the ones adapted from Ch.14 of The Human Body and Health and Illness by Hurley. They're really good at breaking things down.
They are very clear, step by step. So we'll look at, how they're built, the hormones they make, how it's all controlled, and what happens when things go wrong. Think Graves' disease, Hashimoto's, calcium issues.
Sounds good. Let's start with the thyroid itself. What's the layout? Where is it?
Okay, so picture a butterfly. It's got that kind of shape.
A butterfly?
Yeah, pretty much.
Yeah.
It sits low on the front of your neck, sort of wrapped around the windpipe, the trachea.
Okay.
It has two main parts, the lobes, one on each side,
All right.
and they're connected across the middle by a little strip called the isthmus.
Butterfly-shaped? Hugging the windpipe?
Okay, that location sounds, well, a bit vulnerable. Clinically speaking, why is that spot so important?
Oh, it's hugely important because it's right there on the trachea. Any surgery is tricky. You're working right next to the airway. But here's the kicker.
Yeah.
The parathyroid gland, the other glands we're talking about today, are usually stuck right onto the back surface of the thyroid.
Wait, on the back, so you can't easily get to them without messing with the thyroid.
Exactly. There's no simple detour. To operate on the parathyroids, you often have to go through or around the thyroid.
Ah, I see.
And that's why, it's unfortunately not uncommon during thyroid surgery for the parathyroids to get accidentally damaged or even removed.
Which then causes problems with calcium, right?
Mm-hmm.
We'll get to that, I guess. Precisely. It sets up a whole different set of issues.
Okay, that location point really clicks now. Makes sense why it's so delicate. So this butterfly gland, what hormones is it sending out?
Its main products are two hormones. T3, that's triiodothyronine, and T4, which is thyroxine.
T3 and T4, and their main job is?
Their primary function is cranking up your metabolic rate.
So like the speed your body runs at.
Exactly. How fast your cells turn fuel into energy. And that affects a whole cascade of things.
What kind of things?
Well, body temperature, more metabolism means more heat. Heart rate goes up. Appetite changes. It affects weight gain or loss, how fast food moves through your gut, even alertness.
Wow, okay. They really do set the pace. The notes mentioned T4 is a pro-hormone. What does that actually mean? Is it like not fully ready?
Yeah, that's a good way to think about it. T4 is released in large amounts, but it's mostly inactive. It travels around, and then at the target tissues, enzymes convert it into T3.
And T3 is the active one.
T3 is the really potent one, yeah. That's what binds to the receptors and gets the metabolic job done. T4 is more like the stable transport form.
Okay, that makes sense. A sort of activation on demand system.
Yeah.
Now, you mentioned making these hormones. What does the thyroid need to do that?
It absolutely needs iodine.
Ah, iodine, the stuff in iodized salt.
That's the main source for many people, yep. Without enough iodine, the thyroid just can't construct T3 and T4 molecules.
And if you're deficient, what happens then?
The classic result is a goiter. The thyroid gland actually gets bigger. It enlarges.
Why bigger if it can't make the hormone?
Because the pituitary gland keeps sending the signal TSH, which we'll talk about yelling, make more hormone. The thyroid tries to obey by growing larger, hoping to grab every last bit of iodine floating by. It's working hard, but it lacks the key ingredient.
Huh. The notes also flag smoking as a risk here. Something about iodine.
Right. Some chemicals in tobacco smoke, thiocyanate is one, can actually interfere with the thyroid's ability to take up iodine from the blood. So even if you're getting enough iodine, smoking can block its use.
Okay, so iodine is crucial. But what tells the thyroid, make more now or slow down? Who's giving the orders?
That comes from higher up the anterior pituitary gland. Remember that one?
Yep, from our last deep dive.
It releases TSH, thyroid-stimulating hormone.
TSH. Okay, now, this sounds like a classic point of confusion. TSH comes from the pituitary and tells the thyroid what to do. It's not the actual hormone made by the thyroid that controls metabolism itself.
Exactly. You've hit on a super common mix-up. TSH is purely the signal. It travels to the thyroid and stimulates it to make and release T3 and T4. TSH itself doesn't warm you up or speed your heart rate.
Got it. Signal versus action hormone.
And the whole thing runs on negative feedback, keeps all in balance.
Right, like a thermostat. How does that work here?
Pretty much. If your blood levels of T3 and T4 dip too low, the hypothalamus senses it and tells the pituitary, via a hormone called TRH, to release more TSH.
Okay.
TSH then goes to the thyroid and ramps up T3, T4 production. As those levels rise back to normal.
They tell the pituitary and hypothalamus to ease off.
Exactly. The high levels of T3, T4 inhibit the release of TRH and TSH. It's self-regulating.
So if someone has low T3, T4, you'd expect their TSH to be high because the pituitary is trying hard to stimulate the thyroid.
Precisely. And if T3, T4 are high, TSH should be low, suppressed. Measuring TSH is a really key diagnostic tool for figuring out what's going on.
And all this is controlling metabolism. Just to recap, that's basically all the chemical processes keeping us going.
Sums it up well, all those reactions. And T3, T4 set the speed. Faster speed means warmer, faster heart rate, faster digestion, burning more fuel. Slower means, well, the opposite.
Which leads us nicely into the problems. Hypothyroidism, the slow state.
Hyper means too little. Not enough T3 and T4. Metabolism slows right down.
And a common cause mentioned is Hashimoto's.
Hashimoto's thyroiditis, yeah. It's an autoimmune disease. Your own immune system attacks and damages the thyroid gland.
Ouch. So if your engine's running slow, what kind of symptoms show up?
Think slow, fatigue, like real exhaustion, weight gain that's hard to explain, feeling cold when others aren't, cold intolerance. Digestion slows down, so constipation is common. And mood can be affected too, often leading to depression.
Okay. Now here's something interesting from the notes. You can get a goiter, an enlarged thyroid, even with hypothyroidism. How does that work if the gland isn't making enough hormone?
Good question. It goes back to that TSH signal. If the thyroid is damaged, say by Hashimoto's, it can't make enough T3, T4, so blood levels are low.
Right.
The pituitary sees those low levels and cranks out tons of TSH, shouting, make more hormone. Even though the damaged thyroid can't respond properly by making hormone, that constant, strong TSH stimulation can still cause the gland tissue itself to grow.
The signal is high, even if production is low, so the gland swells up, trying to respond. Makes sense. And the treatment is
Usually straightforward replacement. Taking synthetic thyroid hormone, like levothyroxine, every day to bring your levels back up to normal.
Okay, that covers the sawdown. What about the flip side, hyperthyroidism?
Hyper means too much. Too much T3 and T4. Metabolism is in overdrive.
And the notes point to Graves' disease as a common cause here.
Graves' disease is the classic example, yes. Another autoimmune issue, but this time it works differently.
That's so.
Instead of destroying the gland, the immune system makes antibodies that actually mimic TSH. They dock onto the thyroid's TSH receptors and constantly stimulate it, telling it to make hormone nonstop, regardless of the actual TSH level from the pituitary.
Whoa, so the gland is getting a continuous go, go, go signal even when it shouldn't be.
Exactly, leading to way too much T3 and T4.
So if everything's sped up, what symptoms would you expect? Just the opposite of hypo.
Pretty much. Anxiety, jumpiness, weight loss, often just by eating more because you're burning calories so fast, feeling hot all the time, heat intolerance, diarrhea because digestion is too quick, a racing heart, maybe palpitations.
And there's that specific eye symptom mentioned.
Ah, yes. Ophthalmos, that bulging appearance of the eyes. It's caused by inflammation and swelling in the tissues behind the eyes, and it's strongly associated with Graves' disease.
Right, I've seen pictures of that. Very distinctive. And treating hyperthyroidism sounds like you need to somehow shut down that overactive gland.
That's the goal. Often it involves either surgically removing a large part or sometimes all of the thyroid gland.
Wow.
Or another common treatment is radioactive iodine therapy. You take a capsule, the iodine is selectively absorbed by the overactive thyroid cells, and the radiation destroys them.
But wait, if you remove or destroy the thyroid to treat hyperthyroidism, don't you then make the person hypothyroid?
You absolutely do. That's the trade-off. These treatments are designed to stop the overproduction, but they usually result in the person not being able to make enough or any thyroid hormone afterwards.
So they end up needing the thyroid hormone pills anyway?
Almost always, yes. Lifelong thyroid hormone replacement is typically necessary after surgery or radioactive iodine for hyperthyroidism. You trade one problem for another, but hypothyroidism is generally easier and safer to manage long-term with medication.
Okay, that's a really important clinical point. So that's the thyroid's world metabolism, T3, T4, iodine, TSH, hyper. Let's switch gears to those little guys hiding behind it, the parathyroid glands.
Right, the parathyroids, usually 4 tiny glands like little grains of rice, stuck on the back, the posterior side of the thyroid.
And their job is totally separate from the thyroid's metabolism role.
Completely different. Their one and only major job is to regulate calcium levels in your blood.
Calcium controllers.
Okay,
What hormone do they use?
they make PTH, parathyroid hormone.
Yep.
And its main effect is to increase blood calcium levels when they start to drop.
Okay, PTH raises calcium. Where does the body keep most of its calcium anyway? Isn't it mostly in bones?
Overwhelmingly, yes. Bones are the body's huge reservoir of calcium stored away in the mineral structure.
Like a calcium bank account.
Exactly like that. And bones aren't just static blocks. They're constantly being remodeled. You have cells called osteoblasts that build bone and osteoclasts that break down bone.
And PTH talks to these cells, specifically the osteoclast, the breakdown crew.
Precisely. When your blood calcium level dips, even slightly, the parathyroid glands sense it immediately and release PTH.
Okay, PTH is released. What does it do then?
It acts in three main places to bring calcium levels back up. First, it stimulates those osteoclasts in the bone to dissolve some bone matrix and release calcium into the blood.
So withdrawing from the bone bank,
Yep. Second, it goes to your intestines and boosts the absorption of calcium from the food you eat.
getting more from your deposits.
Right. And third, it acts on your kidneys and tells them to reabsorb more calcium from the fluid that's being filtered, reducing how much calcium you lose in your urine.
Closing the withdrawal slip at the kidney counter. Got it. Bone, gut, kidneys, all to increase blood calcium.
That's the triple action of PTH. And naturally, it's another negative feedback loop.
So low calcium triggers PTH, PTH raises calcium, and then the normal calcium level tells the parathyroids to chill out.
Exactly. Stops releasing so much PTH. Keeps things nice and stable.
The notes mention calcitonin, too, from the thyroid. Is that important?
Calcitonin does come from the thyroid, and it has the opposite effect. It tends to lower blood calcium, mostly by slowing down those osteoclasts. But honestly, in adults, its role seems pretty minor compared to PTH. PTH is the major player in raising and maintaining calcium levels day to day.
Okay, so PTH is the star for calcium. Why is keeping calcium in such a tight range so critical? You mentioned nerves and muscles.
Oh, it's absolutely fundamental. Calcium ions are essential for nerve impulse transmission, for muscle contraction, including your heart muscle, for blood clotting, for the release of neurotransmitters and hormones. I mean, the list goes on. If calcium levels get too high or too low, these basic vital processes start to malfunction, sometimes dramatically.
Okay, that makes sense why it needs such precise control. Which leads us to what happens when the parathyroids aren't working right. Hyperparathyroidism. Too much PTH.
Right. Too much PTH means it's constantly pulling calcium out of bones, boosting absorption, cutting losses at the kidney, even when blood calcium is already normal or high. This leads to hypercalcemia, too much calcium in the blood.
And what does too much calcium do to you? You mentioned the bone bank.
Yeah, chronically high PTH can weaken bones, making them brittle and prone to fractures. That's the bones, part of the classic mnemonic. All that extra calcium being filtered by the kidneys can form kidney stones. It can cause muscle weakness and sometimes gastrointestinal issues like constipation or abdominal pain, abdominal groans. And sometimes it affects mood or thinking, psychiatric overtones.
Stones, bones, groans, and overtones. Catchy. Okay, what about the opposite? Hyperparathyroidism. Too little PTH.
That means not enough PTH to keep blood calcium levels up. Calcium stays locked in bone, you don't absorb as much, and you lose more in the urine. The result is hypocalcemia, low blood calcium.
And low calcium symptoms, they sounded pretty immediate and nerve muscle related.
They often are. Low calcium makes nerve and muscle cells hyperexcitable, meaning they fire off signals way too easily.
So like,
You might get tingling, often around the mouth or in the fingers and toes. That's called paresthesia. Muscle twitching, spasms, painful cramps. In severe cases, you can get tetany-sustained, painful muscle contractions. It can even affect the larynx muscles, making breathing difficult. It's serious.
wow. And you stressed earlier that this hypoparathyroidism causing hypocalcemia is a major risk after thyroid surgery.
A really significant one, yes. Because those tiny parathyroid glands are physically located right on the thyroid, they are very vulnerable during thyroid surgery. If they're accidentally removed or their blood supply is damaged, PTH levels plummet, leading to post-operative hypocalcemia. Something surgeons are very careful about, but it remains a known complication.
Man, it really drives home how anatomy dictates function and risk. Okay, let's try applying this with those case examples from Mr. Hostler's notes. First one. A patient had thyroid surgery 2 days ago. Now they have tingling around their mouth, fingers, toes, painful leg cramps, and the doctor taps their cheek and their facial muscles twitch Ch.14 sign.
Okay, so putting it all together,
Yeah.
recent thyroid surgery, the location of the parathyroids, and those specific symptoms, tingling, cramps, twitching, what's likely going on hormonally and with their calcium?
Well, the surgery is the huge clue right near the parathyroids. And those symptoms scream nerve and muscle hyperexcitability. That points directly to low calcium, which would be caused by damage to the parathyroids during surgery, leading to low PTH. So hypoparathyroidism causing hypocalcemia.
Textbook reasoning, absolutely.
Yeah.
The surgery likely compromised parathyroid function, PTH dropped, calcium levels fell, and the low calcium is causing those neuromuscular symptoms like the tingling and the positive Chvostek sign. Perfect application.
Cool. Okay, second case. 33-year-old woman complains of constant fatigue, gained weight, always cold, constipation. Labs show low T3 and T4, but high TSH.
All right. Connect the symptoms, the slowing down with those lab results. Low thyroid hormones, but a high stimulation signal. What condition does that fit, and why do those symptoms match?
Okay, the symptoms tired, weight gain, cold, slow digestion, all sound like a slow metabolism. The labs confirm it. Low T3, T4, the actual metabolic hormones. But the TSH is high, meaning the pituitary is trying really hard to get the thyroid working. So the thyroid itself must be the problem. It's not responding to the TSH signal. That's the classic pattern for primary hypothyroidism, maybe caused by something like Hashimoto's that we talked about. The low T3, T4 is what's causing her slow metabolism symptoms.
Exactly right. You've nailed the interpretation. The gland is failing. The pituitary is trying to compensate by yelling louder with TSH, but it's not working. And the lack of T3, T4 explains all those systemic slowdown symptoms. These cases really show how understanding the underlying physiology helps make sense of clinical presentations.
Yeah, they really do. It's not just memorizing facts, it's connecting the dots.
That's the goal.
Okay, let's do a quick wrap-up of the main points from today's deep dive.
Sure. We covered the thyroid, that butterfly gland in the neck. Its job is metabolism, using T3 and T4. It needs iodine to make them, and it's controlled by TSH from the pituitary via negative feedback. Remember, TSH is the signal. T3, T4 do the work.
And problems lead to hypothyroidism, metabolism too slow, common cause Hashimoto's, symptoms like fatigue, weight gain, feeling cold, or hyperthyroidism, metabolism too fast, common cause Graves, symptoms like anxiety, weight loss, heat intolerance, maybe bulging eyes. Treatment often leads to needing hormone replacement.
Then we get the parathyroids, 4 tiny glands on the back of the thyroid. Their job, calcium control. They release PTH to raise blood calcium.
How does PTH do that again?
Acts on bone to release calcium, intestines to absorb more, and kidneys to lose less. This is the main calcium regulator.
Got it. And problems here are about calcium levels. Hyperparathyroidism means too much PTH, leading to hypercalcemia, causing weak bones, kidney stones.
And hypoparathyroidism, often after thyroid surgery, means too little PTH, leading to low calcium hypocalcemia, causing nerve and muscle issues like tingling, cramps, tetany.
And that surgical risk because of the location is a really key point to remember.
Definitely a critical takeaway.
It is wild how these glands sit right next to each other but do such different vital jobs.
The body specialization is pretty amazing.
So, something for you, the listener, to think about. How symptoms that might seem unrelated, maybe mood changes, weight fluctuations, energy levels, even muscle twitches, could actually trace back to the intricate hormonal balancing act performed by these small but powerful glands in your neck. It really shows how interconnected everything is.
That balances everything.
Indeed. And we'll keep exploring that interconnectedness. Next time, following Mr. Hostler's notes further around the body, we'll dive into the thymus and the adrenal glands, more hormones, more vital functions.
Sounds great. Looking forward to it.
Us too. See that on the deep dive?